Inflammatory bowel disease is a chronic disease caused by an unregulated immune response to host intestinal microflora. Two major entities of inflammatory bowel disease have been identified: ulcerative colitis, which is limited to the colon and rectum, and Crohn's disease, which can involve any segment of the GI tract, from the mouth to anus. Patients with inflammatory bowel disease are more prone to develop malignancy later in their lives. Ulcerative colitis patients tend to develop colon cancer, whereas Crohn's disease patients tend to develop cancer in the small intestine. IBD commonly affects teens and people in early 20s. The geographic distribution of IBD is highly variable, but it is more common in developed nations such as North America, Northern Europe, and Australia. However, the incidence of IBD is increasing in regions like Africa, South America, and Asia, where its prevalence was historically low. The hygiene hypothesis suggests that this increasing incidence is related to improved food storage conditions, decreased food contamination, which leads to changes in gut microflora. This may eventually lead to alterations in immune regulatory responses in the gut. This in turn allows some mucosal microorganisms to trigger persistent, chronic inflammation in susceptible individuals. First, let's discuss about the pathophysiology of inflammatory bowel disease. The precise causes for IBD are not yet identified completely. However, most investigators believe that it results from the combined effects of genetic factors, environmental factors, intestinal microflora, and an abnormal host immune response. We will discuss about these factors in more detail in the following sections. If we consider the genetic factors, both Crohn's disease and ulcerative colitis are complex, polygenic diseases, meaning that they are influenced by more than one gene. More than 160 IBD-associated genes have been identified, and most of them are shared between ulcerative colitis and Crohn's disease. Having a positive family history is the major independent risk factor for the development of inflammatory bowel disease. 1 in 5 patients with Crohn's disease and 1 in 6 patients with ulcerative colitis will have a first-degree relative with the disease. In Crohn's disease, the concordance rate for monozygotic twins is about 20 to 50%, and in ulcerative colitis, it is about 15%. Major associated gene in IBD is nucleotide oligomerization binding domain 2 gene. NOD2 protein is expressed in epithelial cells, macrophages, and endothelial cells. This protein acts as an intracellular sensor of bacterial peptidoglycan. In addition to NOD2 gene, autophagy genes and genes of Th17 pathway are also associated with inflammatory bowel disease. Mutations in these genes leads to a significant risk of Crohn's disease. Mutations in genes associated with mucosal barrier function increase the risk of ulcerative colitis. Moreover, mutations in HLA genes are found to play a role in modifying the disease. Genetic factors influence the risk of inflammatory bowel disease by causing following abnormalities: disruption of epithelial barrier integrity, mainly due to the defects in the intestinal epithelial tight junctions; deficits in autophagy; deficiencies in innate pattern recognition receptors; deficiencies in components of inflammasomes, which is a component of the innate immune system. Inflammasome triggers caspase-dependent processing of inflammatory mediators that aids in bacterial killing. In addition, genetic factors lead to problems with lymphocyte differentiation and defects in the chemical barrier function, such as decreased human alpha-defensin levels. Alpha-defensin is a small peptide that have antibacterial properties secreted by intestinal paineth cells. Reduced levels of alpha-defensin may lead to inappropriate growth of certain bacteria that can trigger IBD. Now let's come to the environmental factors. Smoking is one of the major environmental factors. Patients with Crohn's disease are more likely to be smokers, and smoking has been shown to exacerbate Crohn's disease and increase the risk of disease recurrence after surgery. By contrast, there is an increased risk of ulcerative colitis in non-smokers. In addition, non-steroidal anti-inflammatory drugs, hygiene, which we have already discussed about, Nutritional factors such as high sugar and fat diet and psychological factors like chronic stress and depression are likely to increase the risk of inflammatory bowel disease. Appendicectomy reduces the risk of ulcerative colitis, but it increases the risk of Crohn's disease. If we take intestinal microflora, patients with IBD have an altered gut bacterial flora, known as intestinal dysbiosis. This is characterized by reduced diversity of microbial species, higher concentrations of E. coli and bacteroids, and lower concentrations of bifidobacteria and Faecalibacterium. Abnormal host immune response plays a major role in inflammatory bowel disease. Patients with IBD tend to have deficiencies in aspects of innate immune system, such as deficits in autophagy, deficiencies in innate pattern recognition receptors, deficiencies in components of inflammasome, and deficiencies in mucosal chemical barrier function. We have already discussed about these abnormalities under genetic factors. These deficiencies in the innate immune system leads to an exaggerated adaptive immune response to the intestinal microorganisms. I have taken this image from the Robbins textbook of pathology. It shows how the immune response triggers the pathogenesis of inflammatory bowel disease. Due to the loss of epithelial integrity and impaired mucosal barrier function, bacteria and their products leak through the epithelium. Then the dendritic cells process bacterial antigens and present them to naive T cells. Then these naive T cells differentiate into effector and regulatory T cells. Effector T cells then secrete various cytokines, including interleukins and, most importantly, gamma interferon, which causes macrophage activation. Activated macrophages then secrete more cytokines, including TNF-alpha, interleukin-1, and interleukin-6, which cause direct damage to the intestinal mucosa. Moreover, they trigger the recruitment of more and more leukocytes to the site in a vicious cycle, which ultimately leads to more and more epithelial damage. Now let's discuss about the morphologic features of inflammatory bowel disease. As already mentioned, Crohn's disease may affect any part of the GI tract from the mouth to anus. But it has a particular tendency to affect the terminal ileum and ascending colon, which is known as the ileocolic disease. It can also involve only a single area of the gut, like the terminal ileum, or multiple areas with relatively normal bowel in between. These are known as skip lesions. Skip lesions are characteristic for Crohn's disease and may help differentiate from ulcerative colitis. In some patients, the disease is limited to the small intestine. Sometimes it involves the whole of the colon without macroscopic small bowel involvement, which is known as total colitis. Stricture formation is common in Crohn's disease. Intestinal wall is thickened and rubbery as a consequence of edema, inflammation, and submucosal fibrosis. Earliest lesion in Crohn's disease is known as the aphthous ulcer, which can progress into elongated, serpentine ulcers, as you can see in this picture. These ulcers typically extend the full thickness of the intestine, so-called transmural ulcers. Transmural ulceration can lead to formation of fistulae. These ulcers have a patchy distribution. Therefore, sparing of interspersed mucosa is seen. This gives a cobblestone appearance to the affected area. In this picture, you can see a normal mucosa in the left side and a mucosa with Crohn's disease in the right side. Appreciate the cobblestone appearance in Crohn's disease. Here is a gross image of the mucosa of a Crohn's disease patient. The elevated areas of the affected mucosa represent the normal tissue, whereas the depressed areas represent the diseased tissue. Microscopic features of active Crohn's disease include abundant neutrophils that infiltrate and damage crypt epithelium. Clusters of neutrophils within a crypt are referred to as crypt abscesses and are often associated with crypt destruction. Repeated cycles of crypt destruction and regeneration lead to distortion of mucosal architecture. The normally straight and parallel crypts take on bizarre, branching shapes and unusual orientation to one another. Epithelial metaplasia is also another consequence of chronic relapsing injury. Metaplastic cells resemble gastric antral glands, known as pseudopyloric metaplasia. Painith cell metaplasia may also be seen, usually in the left colon, where Painith cells are usually absent. presence of non-caseating granulomas is a hallmark feature in Crohn's disease. However, only about 50% of patients with Crohn's disease will have granulomas. They may also present in the mesenteric lymph nodes. Cutaneous granulomas often form nodules, known as metastatic Crohn's disease. Ulcerative colitis always involves the rectum and extends proximally in a continuous manner to involve a part or all of the colon. In this image, diagram A shows ulcerative colitis that has affected only the rectum. Diagram B shows ulcerative colitis that has affected both the rectum and the colon. If only the rectum is affected, it is known as pertitis. If the rectum, sigmoid, and descending colon are affected, it is known as left-sided colitis. And if the entire colon is affected, it is known as pancolitis or extensive colitis. Small intestine is normal, although mild inflammation in the mucosa of distal ileum may present in severe cases. This condition is known as backwash iletus. Involved colonic mucosa may be slightly red and hemorrhagic or may have extensive, broad-based ulcers. Here is a comparison between a normal mucosa and one with ulcerative colitis. Unlike in Crohn's disease, there is no cobblestone appearance and the ulcers are more continuous. Here is a gross image of a colon with ulcerative colitis. Ulcers in ulcerative colitis are aligned along the long axis of the colon. Isolated islands of regenerating mucosa often bulge into the lumen to create pseudopolyps, as you can see in this picture. Here is a gross image showing pseudopolyps. Tips of these polyps may fuse to create mucosal bridges, as you can see in this picture. Chronic disease may lead to mucosal atrophy and loss of mucosal folds. Unlike in Crohn's disease, mural thickening of the affected area is not present and strictures do not occur. However, inflammation can damage the muscularis propria and disturb neuromuscular function, leading to colonic dilation and toxic megacolon, which carries a significant risk of perforation. Microscopic features of ulcerative colitis are much similar to Crohn's disease and include inflammatory infiltrates, crypt abscesses, crypt distortion, and pseudopyloric epithelial metaplasia. In addition to those, goblet cell depletion is also seen in ulcerative colitis. Inflammatory process is diffuse and generally limited to the mucosa and superficial submucosa. There are no skip lesions in ulcerative colitis. Mucosal atrophy, submucosal fibrosis, and distorted mucosal architecture will remain even after the healing of lesions. And granulomas are not present in ulcerative colitis. Now let's discuss about the clinical features, diagnosis, and treatment of Crohn's disease and ulcerative colitis separately. Let's take Crohn's disease first. Major symptoms include diarrhea, abdominal pain, and weight loss. Constitutional symptoms like low-grade fever, malaise, lethargy, anorexia, nausea, and vomiting may also be seen. And in about 15% of patients with constitutional symptoms, there are no gastrointestinal symptoms. Reduced growth velocity and delayed puberty may be the main presenting complaints in children. Despite the recurrent nature of this condition, some people are almost asymptomatic. However, patients with severe disease have frequent recurrences and progress from inflammatory to stricturing and penetrating disease. Approximately 50% of patients will require an intestinal resection within 5 years of diagnosis. And it is important to note that above clinical features may vary depending on the region of bowel that is affected. For example, diarrhea occurs in about 80% of patients with colonic disease, that usually containing blood. And steatorrhea occurs in small intestinal disease. Abdominal pain can be colicky, suggesting obstruction, and it usually has no special characteristics. And sometimes in colonic disease, only minimal discomfort may present. Crohn's disease can also present as an emergency with acute right iliac fossa pain, mimicking appendicitis. In these patients, inflammation is higher in the terminal ileum. Crohn's disease can be complicated by anal and perianal disease, and this is the presenting symptom in about 25% of cases. Some of these complications include perianal and ischiorectal abscesses, anal fissures, perianal fistulae, and hemorrhoids. Physical signs of Crohn's disease are few. Weight loss and signs of malnutrition may be seen on examination. Aphthous ulceration of the mouth is often seen. Abdominal examination is usually normal, although tenderness may occasionally present. Anus should always be examined for perianal abscesses, fissures, edematous anal tags, and other complications. Now let's discuss about the diagnosis. Crohn's disease is initially diagnosed on the basis of a combination of clinical, laboratory, histologic, and radiologic findings. Laboratory studies are generally non-specific and may help in supporting the diagnosis and managing the disease. Common findings in blood tests include the following: anemia, which may be normochromic normocytic anemia of chronic disease or iron deficiency anemia. Raised ESR and CRP levels. Hypoalbuminemia in severe disease. And liver biochemistry may also be abnormal. Serologic tests may also help in the diagnosis of Crohn's disease. In most of the patients with Crohn's disease, anti-Saccharomyces cerevisiae antibodies are present. And perinuclear anti-neutrophil cytoplasmic antibodies are negative. Stool tests for Crohn's disease include stool cultures and Clostridium difficile toxin assay. Fecal calprotectin and lactoferrin are also raised in active intestinal disease. Endoscopic visualization and biopsy is essential in patients with suspected Crohn's disease. Colonoscopy is performed when colonic involvement is suspected. Upper GI endoscopy is needed to exclude esophageal and gastroduodenal diseases in patients with relevant symptoms. Capsule endoscopy is also useful, but it only detects mucosal changes. Various imaging modalities are also available to aid in diagnosing the condition, including barium follow-through, CT scan with oral contrast, ultrasound scan, and MRI enteroclysis. This image shows a barium follow-through radiograph in Crohn's disease. Small yellow arrows in the left side denote a stricture in the small intestine. Now let's discuss about the treatment. The aims of management of Crohn's disease are to induce and then maintain the clinical remission of the disease and to achieve mucosal healing in order to prevent disease progression and complications. Patients with mild symptoms and no evidence of extensive disease should receive symptomatic treatment only. Smoking should be stopped. Anemia should be treated with appropriate replacement therapy, such as folic acid, iron, and vitamin B12. Glucocorticoids are commonly used to induce remission in moderate to severe attacks of Crohn's disease. And it is important to note that alternative causes for the symptoms should be excluded before commencement of immunosuppressive therapy. Antibiotics are used to treat secondary complications such as abscesses. Exclusive enteral nutrition is another treatment modality that is commonly used in pediatric practice, but it is not widely indicated for adults. Maintenance of remission is the next step in managing Crohn's disease. All patients require regular monitoring to exclude persistent intestinal inflammation. Patients with the disease that has a good prognosis, like older age at diagnosis, no perianal disease, limited ulceration, and being a non-smoker, may not require regular maintenance therapy. But patients with the disease that has a poor prognosis, like younger age at diagnosis, extensive small intestinal disease, or deep colonic ulceration, complicated with perianal disease, and being a smoker, will require regular maintenance therapy. Commonly used drugs in maintenance therapy include azathioprine, mercaptopurine, methotrexate, and anti-TNF agents like infliximab. Indications for surgical management of Crohn's disease include the following: failure of medical therapy with acute or chronic symptoms producing ill health. Complications like toxic dilation, obstruction, perforation, abscesses, and fistulae. Failure to grow in children despite medical treatment. And presence of perianal sepsis. However, it is important to note that surgery should be avoided when possible and minimal resections undertaken during a surgical procedure. Ulcerative colitis is a relapsing disorder characterized by attacks of blood and mucus diarrhea, accompanied by lower abdominal pain and cramps that are temporarily relieved by defecation. These symptoms may persist for days, weeks, and months before they subside. General features like malaise, lethargy, anorexia, and weight loss may also present. Aphthous ulceration in the mouth may be seen. In most patients, it runs a course of remissions and exacerbations. Proctitis is characterized by frequent passage of blood and mucus, urgency, and tenesmus. In an acute attack of left-sided or extensive ulcerative colitis, patients have bloody diarrhea, passing up to 10 to 20 liquid stools per day, usually occurring at night, and urgency and incontinence. In general, there are no specific findings on examination. Abdomen may be distended or tender when palpated. Tachycardia and pyrexia are signs of severe colitis, and immediate admission is essential. The anus is usually normal. Rectal examination will reveal the presence of blood. Sigmoidoscopy is usually abnormal, showing and inflamed, bleeding, friable mucosa. Toxic megacolon is a serious complication of acute severe colitis. The plain abdominal X-ray shows a dilated, thin-walled colon with a diameter of more than 6 centimeters, and it is filled with gas. It is a particularly dangerous stage of advanced disease, with high risk of perforation and high mortality. Now let's discuss about the diagnosis of ulcerative colitis. Endoscopy with mucosal biopsy is the gold standard investigation for the diagnosis of ulcerative colitis. It also allows assessment of the disease activity and extent. Imaging studies include plain abdominal X-ray in acute severe attacks to exclude toxic dilation. However, disease activity cannot be assessed by an X-ray. Other imaging studies are rarely indicated in ulcerative colitis. Blood tests will reveal raised white blood cell and platelet counts, raised ESR and C-reactive protein levels, and positive perinuclear anti-neutrophil cytoplasmic antibodies, which is contrary to Crohn's disease, where P-ANCA is negative. Stool tests are indicated to look for Clostridium difficile toxin, and stool microscopy to exclude amoebiasis. Fecal calprotectin and lactoferrin are also elevated in ulcerative colitis. Treatment of ulcerative colitis includes medical and surgical management. The mainstay of treatment for ulcerative colitis is an aminosalicylate, which acts topically in the colonic lumen. The active moiety of these drugs is 5-aminosalicylic acid, which is absorbed into the blood by the small intestine. Therefore, various aminosalicylate preparations are designed to deliver the active 5-aminosalicylic acid into the colon. For proctitis, rectal 5-ASA suppositories are the first-line treatment. Oral 5-ASA can be added to increase remission rates. However, some people do not respond to 5-ASA and require oral prednisolone. For left-sided colitis, topical 5-ASA enemas are the first-line treatment. Oral 5-ASA can be added to increase remission rates. People do not respond to 5-ASA will require oral prednisolone. Treatment of severe colitis is more or less similar to left-sided colitis. While the treatment of ulcerative colitis remains primarily medical, surgery continues to have a central role because it may be life-saving and reduces the long-term risk of cancer. Indications for surgery include severe colitis that fails to respond to medical treatment and chronic active refractory disease.